Welcome to The Explainer. Today we're diving into the fascinating, decades-long scientific journey to measure, treat, and ultimately manage diabetic retinopathy. We're going to look at how standardizing a disease, literally figuring out how to measure it, unlocked what are essentially medical miracles. But, as you'll see, despite all these incredible breakthroughs, this condition is still a massive public health challenge, especially as our population ages.
But before we even get into the science, take a look at this absolutely staggering statistic from the Los Angeles Latino Eye Study, or LALS. Nearly 1 in 5, that is 19.4% of Latinos over the age of 80, developed visual impairment in just a 4-year window. Let that sink in for a second. Almost 20% in just 4 years. Keep that number in mind as we go, because it really represents the human stakes of the science we're about to explore.
So here's our roadmap for this explainer. 1. The diabetic blindness epidemic. 2. Grading the severity. 3. Landmark clinical trials. 4. The anti-VEGF revolution. And finally, 5. Real-world public health impact.
Let's kick things off with Section 1, the diabetic blindness epidemic.
To actually fight this anatomical enemy, we first have to understand exactly what we're up against. Diabetic retinopathy, or DR, is driven by chronic high blood sugar, hyperglycemia. Basically, this causes microscopic vascular damage right inside the eye, and this damage leads to severe vision loss, which is often made a whole lot worse by a dangerous swelling in the center of the retina. We call that clinically significant macular edema, or CSME. So we're not just talking about slightly blurry vision here. This is a progressive physical breakdown of the eye's delicate plumbing system.
Moving on to Section 2, grading the severity. You know the old saying, right? You can't treat what you can't measure. Well, Dr. Srinivasada hits the nail on the head here, pointing out that the Early Treatment Diabetic Retinopathy Study, or ETDRS, established a highly reliable benchmark that truly changed the game. Published nearly 3 decades ago, ETDRS Report 10 acts as this sort of master key for all modern clinical trials. It finally gave doctors a common, standardized language to stage exactly how severe the disease was. So how does that look in practice? Well, the ETDRS grading scale breaks the disease down into very distinct steps. It starts at mild, non-proliferative retinopathy, which you can spot by just single microaneurysms. Then it steps up to moderate, and then severe NPDR. Severe is actually defined by the famous 4-2-1 rule. That means severe hemorrhages in 4 quadrants of the eye, venous beating in at least 2 quadrants, or intraretinal microvascular abnormalities in 1 quadrant. And finally, it hits the most advanced stage, proliferative DR. This involves the growth of really fragile, dangerous new blood vessels. Having this incredibly precise granular scale meant that for the first time, doctors could track if a treatment was actually moving a patient backward or forward on these steps, a real game changer.
Which brings us to Section 3, landmark clinical trials.
Now armed with that standardized grading scale, researchers were finally able to launch massive, highly coordinated clinical trials. And this progression spans decades. Back in the 1970s, the Diabetic Retinopathy Study proved that pan-retinal laser treatments, which literally meant burning parts of the eye to save the rest of the vision, could actually reduce severe vision loss by over 50%. Fast forward to 1993, the DCT trial proved that intensive blood glucose control slows the progression of retinopathy by a massive 76% in type 1 diabetics. And then the UK PDS study proved the exact same thing for type 2 diabetics by combining glucose and blood pressure control. So we went from having zero systemic proof to knowing exactly how to put the brakes on this blindness.
Section 4, the anti-VEGF revolution.
Standardizing the disease didn't just validate those early treatments, it actually paved the way for a modern pharmacological revolution. Guys, we are looking at a true paradigm shift here. The older standard relied on those scatter or focal laser therapies. And yes, those lasers were effective, but they were inherently destructive, right? You had to destroy parts of the retina just to stop the disease from getting worse. But the modern era? That introduces anti-VEGF injections, like ranibizumab and aflibercept. Instead of just halting the disease, these drugs specifically target the growth factors causing those leaky blood vessels, which means they can actually regress the disease and reverse those severity scores we talked about earlier.
And because we have that ETDRS scale, recent trials like VISTA, VIVID, and RIDE-RISE could definitively prove an absolutely incredible claim. Anti-VEGF injections reverse diabetic retinopathy by 2 steps or more in anywhere from 30% to over 70% of patients. Think about that for a second. We aren't just putting on the brakes anymore. For a huge percentage of high-risk patients, we can literally put this disease in reverse.
Section 5,
Real-world public health impact.
Okay, so we have these incredible medical interventions that are proven in very strictly controlled clinical settings. But who's actually getting sick out in the real world? To answer that, we turn back to the Los Angeles Latino Eye Study. Using standardized US and WHO visual impairment criteria, this massive population-based study tracked real-world outcomes over a 4-year period in over 4,600 participants, mostly of Mexican ancestry. And what's cool is they didn't just measure best-corrected vision, they measured presenting vision, basically how people are actually seeing as they walk around and live their daily lives.
And the real-world epidemiological data reveals a pretty stark demographic reality. As you can see, as this population crosses from their 50s into their 60s, 70s, and 80s, the incidence of both visual impairment and outright blindness doesn't just go up, it aggressively, violently accelerates.
Let's put some human faces to that curve. A Latino patient in their 40s has a tiny 0.7% risk of developing visual impairment in their first eye over 4 years. But for those 80 and older, that risk jumps to a profound 14.6%. That is a massive, overwhelming generational burden of disease creeping into our oldest and most vulnerable communities.
The crucial takeaways from the LALA's data are honestly sobering. First off, Latinos have the highest incidence of visual impairment reported in any U.S. population-based study. Second, and this is probably the most alarming part, there's a domino effect. The overall incidence of losing vision in your first eye is 2.9%. But if you're already impaired in one eye, your risk of losing vision in your second eye essentially quadruples to 12.2%. Age, without a doubt, is the absolute strongest predictor of this worsening vision.
Which leaves us with this final provocative thought. We spent decades creating a measure-to-manage master key. We used it to unlock pharmaceutical miracles that can literally reverse the progression of diabetic eye disease. But as the real-world data clearly shows, incidence rates are still skyrocketing in aging, at-risk populations. The science is here, folks, but how do we build the public health infrastructure to actually deliver these medical miracles to those who are going blind while waiting for them? Thank you so much for joining me for this explainer. I hope it gave you a whole new perspective on the intersection of clinical science and public health.